Welcome back. What I'd like to talk about now is HELP syndrome. You can find this information on slide 24 in your PowerPoint. And just to summarize, we were discussing the disorder of hypertension in pregnancy and its progressive nature, if it will indeed progress to preeclampsia, mild or severe, and all of those different manifestations that are evidence that other systems are becoming subject to that vasospasm, or the things that are happening in the pregnant woman's body. Um, and we talked about the changes related to liver congestion. We talked about the changes related to renal impairment. We talked about the changes of neuro, like headaches, visual disturbances, and hyperreflexia. Um, so ultimately, again, if we don't, if the sequelae isn't stopped, then the woman will likely progress to eclampsia, which is seizure activity of the pregnancy. And again, we'll see all those other signs that were leading up to it if she is seizing. Um, However, HELP syndrome, which again tends to go hand in hand with preeclampsia, can sometimes present without those real noticeable changes of gestational hypertension. And HELP stands for hemolysis of the red blood cells, so rapid breakdown of the red blood cells, elevated liver enzymes, showing that there's significant liver function change, and low platelets. Um, Definitively, for HELP syndrome, the platelet count would be less than 100,000. Now, that leaves a gray area because we know platelet counts are normal somewhere between 150 and 400,000. So, is she in full HELP syndrome if she has a platelet count of 125? Well, we look at her manifestations. We look at her other lab values. What is her ALT, AST? What's her SGOT look like? Does she have liver congestion, abdominal pain, distension, epigastric pain, nausea, vomiting? You know, you had 125,000 count of platelets. She's bruising more easily. You have to kind of get back to her baseline. What's the overall shift for her? Regardless, when we see those things happening together, rapid hemolysis, she's going to be anemic, short of breath, pale, perhaps jaundice even, which is really a late sign of HELP. That's certainly those things together. When we look at this condition, we start to say, she's experiencing HELP syndrome. The risk with HELP syndrome is pretty obvious, and that is that if she's not able to coagulate and it becomes a hemodynamic shift, the risk is that she could progress into DIC, disseminated intravascular coagulation. DIC in and of itself is not a term owned by obstetrics. It is the culmination of what happens in the body once clotting factors and coagulopathies, the way the blood coagulates, has been graphically skewed. So what should happen if internally, right, inside, I have beautiful homeostasis that maintains myself, we through fibrinogen networks and platelets and aggregation and all of these wonderful mechanisms that keep us hemodynamically in check daily. Once we've removed those factors or portions of them, or we have overwhelming blood loss, so the body just can't even keep up with it. So it's not just obstetrics. This can happen with someone who's postpartum hemorrhaging. They can go into DIC. This can happen with a traumatic event on the side of the major interstate with loss of limb, right, that challenges life. They can go into DIC. Disseminated intravascular coagulation is basically what happens when the body no longer has the ability to coagulate and keep everything homeostatic. And what happens is that it's hemorrhagic, and at the same time, there's also clot formation that's abnormal. So it's kind of like a system malfunction, if you will, for lack of a more medical term, DIC. This is what can happen for a woman who has help. She no longer has reliable coagulation that's coming from the liver. So what do we do for those women? If she is eclamptic, if she is clearly progressing to HELP syndrome, deliver the baby, magnesium sulfate can be onboarded, loaded, a loading dose to prevent further seizure activity so that this baby can be born. But the only way to definitively and hopefully have her reverse this disorder is to deliver the baby, since it is the pregnancy that was the underlying cause. So, slide 25, some clarifying questions about this disorder. So the first question, what's the difference between primary or essential hypertension, those are the same thing, primary or essential hypertension, and gestational hypertension? So think about that for a minute. What would be the difference? I'm sure you've heard the term primary hypertension or essential hypertension, and now you've learned this new term, gestational hypertension. And my hope is that your answer would be that it's the gestational hypertension is the development of hypertension, elevated blood pressures greater than 140/90 on two separate occasions within a same week, at least 4 hours apart. And primary or essential hypertension is the hypertension we see in the everyday non-pregnant person. So again, when we look at our pregnant population, have we captured baseline information? Are we able to discriminate that this was a primary or an essential hypertension, which is not gestational hypertension? She simply has hypertension that needs to be managed. Does it put her pregnancy at risk? A little bit, right? Because we know if someone has persistent essential primary hypertension, they likely don't have great cardiovascular. And hey, let's go back to the almighty placenta, right? Who loves the placenta? Dawn loves the placenta. The almighty placenta relies on really adequate circulation. And if somebody has underlying hypertension, that can be an issue. But that's a different lecture. We're going to talk about that next week. What we're focusing on today is gestational hypertension, and knowing that difference between the person who's had existing primary essential hypertension or the person who, hey, my blood pressure's been great all my life, and all of a sudden I'm having a baby, and now it's 150/90. Gestational hypertension. The pregnancy is causing this. Another clarifying question, what's the difference between preeclampsia and eclampsia? This is a concept you need to walk away with. Preeclampsia, we know, if you think about it, right? It's somebody who is developing all those systemic responses to this underlying disorder where it's involving some liver, some renal, some neuro, and they are now showing those signs. However, they're not seizing. If they're eclamptic, they're seizing. And then again, the difference between gestational hypertension and the difference between gestational hypertension with HELP, we know if they're gestational hypertension with HELP, that is true liver involvement that has now, impacted the coagulation factors of the liver. So, who is at risk for developing gestational hypertension? Slide 26. We know who are we going to really watch and screen to make sure that we don't miss these signs and symptoms. Maternal age. And when we say maternal age, it's not just the old woman who wants to have her first baby or advanced maternal age over the age of 35, but we're talking about also the very young. We see that as well. So teen, adolescent pregnancies are also at a higher risk. We do see the frequency increase with those two maternal age groups. It is more often seen in a first pregnancy. And again, never been pregnant before. This is a significant change for her body. Is that what precipitates the vasospasm that's occurring throughout her body? Interestingly enough, just because a woman develops gestational hypertension in a first pregnancy does not mean that she will have it in her subsequent pregnancies, the second, the third, and so on. It seems to be, some will, but not all. It seems to be that it's a disorder found most frequently in first pregnancies. So, first pregnancies, greater risk. Somebody who's morbidly obese, so we have a BMI greater than 29. We know that greater than 25 is obese. If her BMI is greater than 29, she is significantly at risk for developing gestational hypertension. She comes to this pregnancy really not in optimal health. So there could be things there that leave her open to this vasospasm situation. Multiples, carry more than one baby, certainly overwhelming on her body. If she has underlying chronic renal disease, kidney disease, that puts her at risk. Getting back to that hypertension, if she had it to begin with, could she then, hypertension, essential or primary, could she then develop gestational hypertension? Yeah, she could. The hypertension would get worse, and then she begins to develop those preeclamptic signs. Starts spilling protein, starts to have headaches, starts to complain of epigastric pain, starts to have hyperreflexia. Yes, she did have underlying hypertension. She's now developed gestational hypertension with preeclampsia. So it does put her at risk. If there's a family history of preeclampsia, so women who have sisters or mothers who had preeclampsia are also statistically at a higher rate of them themselves developing preeclampsia. The diabetic client, not gestational diabetic, we're talking about the diabetic client, type 1, type 2, entering into the pregnancy, they are at statistically a slightly higher risk of developing preeclampsia. And then again, if she had gestational hypertension in a prior pregnancy, we'll watch her closely. Doesn't mean she's going to develop it, but she could, and we have to watch that for sure. So, the manifestations, and we've already talked a lot about those in this PowerPoint, obviously is the hypertension, and that's what we're going to watch. Could somebody develop manifestations of preeclampsia with minimally or marginal blood pressures? Yeah, they could. It happens. There are times when women, like, just, their hypertension is really not at that 140/90, but boy, they have persistent headaches. They come into the office, they had a 5-pound weight gain in a week, protein in their urine, and we say to them, how long has this been happening? Well, it's been going on for about 2 weeks. We obviously going to check fetal well-being. What's the baby's still moving a lot, all of those things. But is it possible? Yeah, it is. It's rare. Usually we see the blood pressure first. I would say go back and look at her baseline. If her blood pressures in the office have been 128/82, which definitively, right, isn't gestational hypertension, but you go back to her baseline and she was, 106/70 for the first 2/3 of her pregnancy, well, that's an elevation for her. So again, hypertension, and within the context of other manifestations and baselines. Proteinuria we've talked about because of the renal impairment. The central nervous system irritability, again, we've talked about the headaches, the little spotty vision, the losing of the peripheral vision, clonus, hyperreflexia, all of those, photophobia, the lights bother them sometimes. The liver changes, we've talked about epigastric, nausea, vomiting, upper abdominal tenderness, bruising easily now, bleeding more often, renal changes, the proteinuria, the oliguria, and then that overwhelming fluid shift that's happening in the body because of the vasospasm and the progression of the disorder. We see that edema, pitting edema. Difference between non-pitting and pitting. Pitting, we depress it, it stays depressed over a bony area is how we check edema, and we measure it, 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, +1, +2, +3, +4. If it's pitting and she's having these significant weight gains, then those are all pretty good indicators of gestational hypertension. I'm going to pause here, upload so I don't have to break it apart, and I'll come back one more time.